We use the word paraphilia to broadly categorize variations in sexual thoughts and behaviors that are considered outside of normal sexual activity. Hopefully, as you read through this chapter, you'll be struck by how many different sexual variations have been documented. People find just a wide breadth of things arousing or behaviors that people engage in. Something else to remember is that the term normal is culturally relative. It's also a fluid term, so it changes over time. Certainly, what we think of as normal and what we think of as abnormal or unusual or different changes based on which culture you're looking at. So, ethnic or racial culture, as well as culture based on what region you live in. So, which country you're coming from, or even within a particular country, norms may differ from region to region. For example, if we want to look at age and think about what is considered normal in terms of who someone should have sexual relationships with, we can see that there's a bit of range in terms of what we think of as adult consenting age. This differs in the US from state to state, country to country, and cultural background to cultural background. Similarly, even within the same culture, what we think of as normal and abnormal can change over time. For example, at one point in this country, we used to consider homosexuality a mental illness or disorder, and it was listed in the DSM. We no longer think that's the case, so how we think about homosexuality has evolved. Similarly, what we think of as immoral or unusual has also changed. At one point, oral sex and anal sex were very taboo, not discussed, and considered highly immoral and unusual. Of course, some people still think those behaviors are immoral and unusual, but the proportion of people who think of oral sex as something that only a tiny percentage of people do has shifted over time. Your book makes a distinction between paraphilia and paraphilic disorders. The most recent version of the DSM makes this distinction as well. So paraphilias are just unusual sexual interests that are relatively harmless. So it's not particularly harmful to the person or to other people. Paraphilic disorders are diagnosed when these unusual sexual interests are either personally distressing, so they're harmful to the person because they're causing psychological distress and possibly causing a lot of other issues to come about, like anxiety or depression, and or they involve victimization of others. So they're perpetrating harm on someone else non-consensually. So where do paraphilias come from? If we're using the biopsychosocial model, we want to be aware of biological factors such as hormones and neurotransmitters, psychological factors such as learning, and social factors. So, for example, if you have poor interpersonal skills, you might be less likely to find partners and therefore gravitate more towards unusual forms of gratification. Your book goes into these in detail. For psychological factors and learning, I have a link on Moodle to an article about rat lingerie. So figuring out why lingerie might be something that people find very sexy and might even develop a paraphilia about using rat research. Another paraphilia is transvestism. These are typically men. There are female transvestites, but it tends to be pretty rare compared to male transvestites. This is when someone dresses as a member of another sex. So typically men dressing up as women because this makes them sexually aroused. This is not because they want to become a member of another sex. It's not that these are men who want to become women or feel that they are women trapped in a male body. It's that they are men who become sexually aroused from dressing up in women's clothes. I have here in bold, and I want to make this very clear, that transvestism is not the same as transgender. The other thing I want to point out, and your book also makes this point, is that there seems to be a myth that transvestism is related in some part to homosexuality. That isn't true. The majority of male transvestites identify as heterosexual. Also, most of them are either married or have been married before. Another paraphilia is sadomasochism. This is when sexual arousal is derived from giving or receiving pain. So those who derive arousal from giving pain are called masochist, and those who derive arousal from receiving pain are called sadist. While pain can be physical, it can also be non-physical. For example, it could be psychological pain in the form of humiliation, verbal abuse, etc. Sadomasochism is sometimes talked about under the umbrella of BDSM. Here I have the definition that the book uses for BDSM. You'll see that there are more than 4 words in there, and that's because there are some disagreements about which BDSM words should be part of BDSM. But these are the most commonly used ones: bondage, discipline, dominance, submission, sadism, and masochism. While pain may be an important factor in many of these types of behaviors, it isn't necessary. For example, bondage and dominance don't have to involve pain. Instead, the focus could be on control. There's also a vast range of behaviors under the BDSM umbrella, and these vary in risk. Also, these vary in terms of how much we worry about the behaviors from a clinical or health perspective. You could have something very mild that has almost no risk. For example, putting a blindfold on someone could be considered part of BDSM. Or you could have more extreme behaviors that do involve physical pain and perhaps scarring or other potentially adverse outcomes such as cutting, electrical shock, or asphyxiation, which is where you deprive someone of oxygen, maybe to the point where they pass out. Those behaviors are more risky and potentially more dangerous. If those are things you practice, you should adopt safety precautions. Something else I want to point out that your book also talks about is that there are many myths surrounding BDSM. This probably comes up a little more recently because BDSM has become more mainstream through things like the book 50 Shades of Grey. One of the myths that have been out there for a while and more recently through these books and have been endorsed by many people is the idea that those who practice BDSM are more likely to have psychological distress and more likely to have been victims of childhood sexual abuse. What the research seems to suggest is that these are myths that are not true. Those who practice BDSM are no more likely to have been victims of sexual abuse or have higher levels of psychological distress. The last paraphilia I'll talk about is pedophilia. Refer to your book for some discussions on additional paraphilias and more detailed discussions on some of the paraphilias that I spoke about today. I want to make sure a couple of things are clear. First, pedophilia is different from child molestation. Pedophiles can be child molesters, and child molesters can be pedophiles, but the two are not the same thing. What pedophilia is referring to is a pattern of sexual attraction to children. Regardless of whether or not they've acted on those urges, if someone has those urges towards children, that makes them a pedophile. Child molestation refers to actual specific actions and behaviors. So if someone has ever fondled a child or had sex with them, that would make them a child molester, regardless of whether or not they have a sexual preference for children. So not all pedophiles are child molesters, and not all child molesters are pedophiles. Pedophilia can be something that happens when someone engages in sexual activities with a child due to urges they have. So they're attracted to the child, or they might have urges, never act on them, but experience distress. Therefore, they can go and seek treatment because they find themselves attracted to children, and this isn't very pleasant for them, and they understand that it isn't socially acceptable. Maybe it fills them with shame or unpleasant feelings, and they want to deal with those feelings. The final note that I have here and that your book covers is that most pedophiles are heterosexual married men. Often when we hear about pedophiles, sometimes there's a myth that they are homosexual men, but this typically isn't the case. Let's say that someone has a pedophilic disorder. So it's not just pedophilia that isn't causing any harm and isn't causing any distress, but something that is highly distressing for an individual and/or is causing harm to someone else. So non-consensual sexual behavior or abuse of a minor. What can be done to treat it? Well, there are a bunch of different medical treatments available. First, we can use medical therapies. One example of this is using chemical castration. As we talked about in a previous chapter, there are some downsides to using chemical castration when treating sex offenders. These include side effects, the difficulty in making sure that the person keeps taking their drug, and the high rate of reoffending when people stop taking the drug. This isn't a cure-all. Another medical therapy that is sometimes used is antidepressants, such as SSRIs. These are used partly because they've been shown to reduce compulsive behaviors. So they're also sometimes used to treat OCD. Some paraphilias may be very similar to OCD in terms of an obsession with one particular thought pattern or a compulsive behavior. Psychological therapies also exist. Again, most revolve around conditioning. So trying to recondition someone to think and behave in a more socially appropriate manner by either increasing the reward of socially appropriate thoughts and behaviors, decreasing the reward of their socially inappropriate thoughts and behaviors, or increasing unpleasantness, and so pairing their paraphilia with something unpleasant so it's no longer as rewarding. Finally, we also use social skills training. Remember that paraphilia is associated with having lower social skill levels. So if we can train people to be better at social interactions, maybe they're more likely to go out there and create socially appropriate relationships and have an outlet for more normative behavior that is less distressing and harmful to others. It's important to remember that treatments aren't perfect. For example, your book discusses a meta-analysis that does find some efficacy for treatments. There's a substantially reduced reoffense rate between those who received treatment and those who didn't. But as you can see, it's not even close to 100% yet. So there's a long way to go regarding research and tweaking treatments to make it more effective. Something else to remember is that treatment is much more successful when sought voluntarily than when mandated. This has implications when we think about what are appropriate things that we want to do in our judicial system for people who have paraphilic disorders and might have caused harm to someone.